Thank you. It's not a case presentation, it's a spotlight lecture. So, can I have the slide, please? Yeah, thank you. Thank you, the organizers, for this opportunity. So, I'll start with the retrieval devices that are tools available for part body retrieval. They have involved. You could have a loop snare, you could have an end snare, 3-loop retrieval system, you could have a basket, you could have a biliary stone forceps, biopsy forceps, or hook retained fragment retriever. Any of the above, all of the above, and multiple trials, and it's just ingenuity and innovation that saves a day. No well-defined procedures are there. The loop can be a micro snare, EM snare, or micro lead snare. Forceps can be vascular retrieval, flexible myocardial biopsy, or mechanical grasping forceps. So I'll start with the retrieval of the wire. So the wire getting broken and left behind is quite common, and it's detrimental and can cause a thrombus or even create an arrhythmia if it's left behind. So the first and the most commonly used is what's called a knuckle twister. It's a simple, safe, and predictable procedure. You just put in another wire. Before you put in the wire, just curve the wire enough to make a J to go with, and go into the J tip, the new wire going into the J tip. As soon as you get near the other wire tip that's there, start twisting it. So you're going in B you have reached the place, in C you started rotation, in D you keep rotating till the time you're sure that you got the guy under control, and then E pull it out. Simple, straightforward, looks easy, but works most of the time. This is just a case, unfortunately, D is not playing. So retrieval of wire is restricted to that. If it doesn't work with that, only we need to think of using any other device that may be required to retrieve the wire. Second and the most common thing that gets lost is the stent. So you have a protocol that can be practiced in your see. If the stent is dislodged, inflate the balloon to slow atmosphere 3 atmospheres, gently pull back. If it's not happening, then pass a new balloon through the stent struts, go beyond the balloon, go beyond the struts, and tightly inflate it, see it, pulling it back. If nothing works, then use the other things like use the retrieval forceps. I just explain each of this with the diagram so that it becomes very easy. And this is the easiest way to do it. So you get a small balloon across through to the other stent. The catch is that I'm presuming that you haven't lost the wire. If you lost the wire, then the chapter becomes totally different. So you just go across the stent, inflate gently, and gently withdraw it. It works most of the time. If it doesn't work, once the balloon is across the wire, you can use a guide liner to get through it. So this is how it looks like. There's the stent. Beyond the stent, you go inflate and gently pull it back, and it slips out. So second option is the same thing what you did for the wire. So you take 1 or 2 wires as you feel like. Just go inside. It can be around the stent, it can be across the stent, it can be through the stent, and do the looping like you did for with the torque. Keep looping the wire till the time you have got a loop around the stent. And if you do it well, this is how it looks like, and the stent usually comes out. Then this is a picture, unfortunately not playing, but this is the way the thing gets looped. This is proximal to the distal stent, which is got trapped, and we have taken it out. And it looks like this in the final picture when the whole thing comes out. So this is the snare stent with multiple wires. So now we coming to resorts which are not very. We have lost the stent. We are not able to wire the stent. We are not able to loop around the stent. That's when you do this crush technique. Specifically, so if you're in a larger vessel and a comfortable vessel, just go with the new stent, go parallel to the previous flow, and just crush it against the wall and deploy the new stent. And if all heroics fail, which happens sometimes, then call the surgeon, request him please pause stent gear, try and help us out. They will open out and they will take out the stent and put a graft and come out. This should be an option that you keep open. So till now it is all simple things that get stuck. Now when the IVS catheter gets stuck, what do you do? So IVS catheter, do not pull or push. If you start pulling it out, you're going to damage the IVS catheter. There is a rotation technique, there is a body weight technique, and depending on what is the guide you use 6 French or less, then you may have to take a tandem 2 ping pong guide system and go in. Otherwise, you have to cut the IVS and go in. I'll show you how it is done. 7 French you can do by putting another balloon and coming out. I'll show you. So the issue is, where does it get stuck? Get stuck in the exit port. So if it's a tortuous lesion, because of the layout like this, it gets caught here. And if it's a calcified lesion, it gets caught in the calcium. So I like to go really fast. So this is how what we do. You pass a wire parallel to it. You take a balloon catheter parallel to it, reach near the IVS catheter, gently dilate the balloon and pull the whole thing back. It usually comes out. So otherwise we'll cut the IVS catheter and then come out of the guideline. If your OCG catheter is stuck, you are in trouble. This is an OCG catheter. We showed you excellent images. You can see all the images. The calcium was done by rota. When we went inside, you see the top one. We got excellent images, and we were greedy. So it was a metal jacketed LED. We went right through the tip of the stent. The wire got dislodged. The stent got caught, and just see how badly the whole thing got damaged. We couldn't even reach the table. Stuck rotablator, call the surgeon. Most important, do that first. And then there are green, I'll take exactly a minute. The green ones are all ones which is recommended how to do it, and the red ones is conservative approach, never do it. You cannot get away with the conservative approach. So there is a mini-star bailout strategy. You pass the balloon subintimal or parallel to the rotawire, dilate and try and pull it out. Otherwise, you cut the rotawire in both the places, pass a guideliner through that into the till the time you reach the rotablade, get the stuck burr, and then jam it through. It usually loosens and comes out. These are the two options you have, and this is the stuck rotabar, how it looks like. I'll quickly go through this in the time. So here you have to understand that the rotor wire is designed in such a way that it will not come back out of the rotabar. So that's the thing that I utilize in this case. So here I have a stuck rota burr in the proximal LED. Luckily for me, the patient remains stable. Otherwise, I would have been in deep trouble because it's at the trifurcation. So then I passed a wire parallel to this, and suddenly I realized that if you have a 7 French catheter with rota burr inside that, nothing else will go through. No balloon will go through. So you have to do a ping pong technique, or I thought before the ping pong technique, I'll gently pull it out. So this is how the pull goes in. I just tucked, hoping like hell that the thing comes out, and you can see that the whole catheter system is getting kinked. It's getting pulled, but eventually what happened was, I was lucky enough. You can see how much of stress I'm putting on the guide, and the thing came out. So I have only time for this much, so I'll stop here. So you may get stuck with anything that you have. Ingenuity is the way forward. If the patient is not stable, kindly send him for surgery. If the patient is stable, you can try any or all of these methods. Thank you.
Thank you, Dr. Mahesh, for a nice presentation. Of course, this topic cannot be covered in 6 minutes. There are a lot many things we have seen broken: catheters, guideliners, all those things, etc. So, comments?
Just invite you to the skip. Yeah.
Thank you. Sometimes the wire gets broken partially and wire untravels the coil. So sometimes it is very tricky to pull it out. You cannot neither push anything in nor pull it out. Sometimes it can create.
So parallel wire with a loop and taking out like a broken wire.
It untravels, but not completely.
Even then. So
the unravel part can ensure the proximal part of the.
agreed. Totally agreed. So you just ignore the unravel segment, go distally beyond into the tip of the segment which is not unravel, catch him there and pull it.
Even then, when you pull it out, the unravel part can dissect the proximal part. So there are some recommendations that a surgery may be better there.
Or a guideline, right?
Anyway, it was a very nice presentation. It was such a short time. I think we can join us here for the rest of the discussion.
I invite Dr. Kundan Patil for his case 10 piggybacking, a nightmare in cath lab.
Good evening all. After a very nice lecture by Mahesh sir, I am presenting one relevant case. Actually, a similar case was presented in the afternoon also, but it's still unusual. It has some factors of its own. So my case was 68-year-old male who was diabetic, hypertensive, and he had CKD also, who presented with acute anterior MI and he was in clip class 3 heart failure. This was the ECG which looked like this. He had severe LV dysfunction. We started initial management of heart failure and shifted him to cath lab. Just on shifting to cath lab, we got creatinine report to be 2.9. So this was the initial angio. So you can see there is plaque in distal LMCA, LAD, ostial total occlusion is there. There is one diagonal which is filling retrogradely, but the origin of diagonal is not visible. Then there are some plaques in ramus. In the ariocaudal, these were little significant. So what I did, I wired it, I did pre-dilatation, and this was after pre-dilatation. Then I stented from LM to LAD. And this was the final result. There was, I don't know what happened here. This plaque was very tight actually, but it was still flowing, and I didn't want to do more intervention. So I shifted him back to cath lab. This is what hardware I had used. The guide catheter was 7 French through femoral root. Both the wires were run through. I did pre-dilatation with 10 SC balloon. I used 3.5 into 36 mm Promus premier stent in LM to LAD, and I had post-dilated it with 4 by 10 mm sapphire NC balloon at 15 atmosphere, so around 4.15 mm. And I had done simultaneous kissing dilation with 2.5 into 10 mm sapphire SC, followed by POT in LM. So this was the case where I kept on getting some mini heart attacks during procedure. After procedure, this was the ECG. Patient was stabilizing, but after half hour, he developed new escalations in lateral leads, and he was worsened clinically. So I had to take him for check angio. Check angio was okay. Just I had doubt with this lesion only. So I decided to go with POVA of that lesion. Otherwise, I would have left. But on background of LAD ischemia, I thought this occlusion may become very significant for the patient. So I did POVA, but after POVA, I noted a small dissection, type B dissection. So for me, it would have been again trouble to shift the patient third time in cath lab. So I was, despite most of these kind of dissections may heal by themselves and may not cause much problem, reluctantly I decided to go for stenting. So what happened, I could negotiate stent at ramus ostium, and I tried to retract the stent. I was planning to do one more simultaneous kissing dilatation, but I felt little resistance inside guide while pulling back the balloon stent, and I had some doubt, so I pulled back the guide and I took one cine. So the balloon has been stripped off, and stent is at ramus ostium. It is hanging into aorta. So what I was planning to actually, I had wire inside the stent. I was planning to do snaring actually. I considered both the options, to entangle wire or else to snare. I was planning to go for snaring, but the patient was restless, and main factor was I was not able to engage the guide again, because the guide was getting stuck at the edge of stent, and it was not possible for me to engage. So this position was very unstable. So basically what happened, I lost the wire also. So this is the wire which has been hanging in aortic root, and this is the stent. Oh, sorry. So this was the stent here, and this is the stent which is hanging inside the root of aorta. So I tried a few catheters to snare out the stent. I had only one option to snare out the stent, and finally, after a lot of attempts, I could snare it out with EBU4. But it had got its body inside this thing with him. So this was most terrifying situation for me, because I had pulled out all the assembly. There was no guide which was engaging LM. The stent which was deployed from LM to LAD, it had also come back with another stent, and I was almost certain that there will be some problem. Although patient was looking hemodynamically stable at that point, I was sure that there will be some dissection in LAD, and I was expecting that patient doesn't collapse on table. Initially I took very small puff of injection after engaging the guide, and once I saw the dye was filling till the end, I wired it immediately, and this is the injection after wiring the LED. I just wanted to be on safe side, not to extend the dissection further down. So immediately I stented from LM to LED, and I took a little longer stent than previous stent in case if there was dissection. This ramus was also flowing well. Again, I did simultaneous kissing dilatation and pot. There was a ramus dissection, but it was flowing well. So eventually, patient recovered well. Total contrast volume was 75 cc. Creatinine was also stabilized on discharge, and he has been under follow-up for almost 13 months. Last January, this was the procedure which we did, and he is doing really well. So on looking back, I think the preparation at L6 hostel, though I had done simultaneous kissing dilatation, it would not have been adequate. I could have used guide extension, but I am not sure whether it would have been helpful. I could have waited for medical management to work, but I can say that retrospectively, and obviously imaging will help, but I didn't have imaging support there, so I had to do without imaging only. Thank you.
Nice demonstration, but was the first stent properly deployed and proper sized? But it came out so easily with the second stent.
Actually, it was not very easily. I could feel some resistance, but I had to pull out the stent. I didn't have any option. Otherwise, another option was to send the patient for surgery, which was very difficult for me. There was resistance. The stent was completely stretched, and I'm not sure. Without imaging, I can't tell actually whether it was not deployed properly or not.
Just 2 hours back, we saw another case where the stent came out.
Such cases are being reported. I know one more case which happened. Like it was posted on Twitter just 2 weeks after this case. So maybe we can see such complications in future. So actually, what I was planning to try with stent snaring the stent, I was going to. I had similar cases before also stent loss. I had wire inside stent initially. I was going to put the gooseneck snare over that wire, so it goes exactly to the stent, and I can push the guide and pull back the stent. Would have been easier than
The second stent must have got entangled with the first stent.
Yes, sir.
Like what? So the summary is the patient survived despite your best efforts.
The first stent was LMP. First stent was LMP.
Yes, sir.
So probably you went subscribe and then.
I did the kissing dilatation, but we can't tell without imaging exactly what happened. I have gone through in detail about what could have happened. Like we do after some complications. Next 3-4 days, I was continuously thinking about it. Few possible.
Probably if you had taken the second stent when there was resistance to a guideline, this might not be.
Yeah, I thought that, but I'm not sure whether
These
it's
are all afterthoughts.
So, yeah, yes, sir.
When did you realize second state is coming out? Only after it came out or immediately when the resistor you
I have mentioned in my presentation that I could see some wire-like structure which was coming when I was pulling the first stent out. So only when I was not sure what is it exactly, because this was beyond my thought at that time. I had not seen anything like this. So only thing when I pulled the whole assembly out and I saw what I have snared, both stents were entangled, and I could not see exactly where it was attached. Before that only my technician, my scrub nurse, he had dismantled both the stents. I wanted to see exactly what had happened at that point.
Thank you. Let us move on to this case. A good case.
Thanks.
The next case is to stent or not to stent. In a case of recurrent stent failure by Dr. Anil Chaudhary.
Good evening, everyone. First and the foremost, I would like to thank everyone for giving me the opportunity to share a case. So, to begin with, a 53-year-old female, diabetes mellitus for the last 10 years, hypertensive for the last 5 years, presented with a non-ST elevation MI in our center. On taking the history, I got to know the whole story. So, in May 2022, she presented with anterior wall MI. On angiography, there was a discrete lesion in LED, and a PDCA2 LED with DES was done at some another center in the city. There was a rapamycin analog stent was placed, a second generation stent. Just after 1 month, she started having angina on exertion, which gradually progressed from class 1 to class 2. Apart from that, she went to the same cardiologist, angiography was done, and there was a total occlusion of LED. She was advised for CABG. CABG was done with Lima to LED, and at this time the LCX had 80% lesion from proximal to mid part, and RCA was having a long segment disease. So this was the thing. Again, after 2 months she started having chest pain, went to another cardiologist. Now this stenting was done to the LCX, and patient was fine for 2 months. Again started having chest pain, decided to go out of the state to some another center in another part of the country, went over there, and now this stent was placed in the RCA. From proximal to mid, the stenting was done, the Lima graft was patent, and patient was discharged. And at the same time, patient was getting all the guideline directed therapies. Again, after 1 month, she started having chest pain. Went to the same cardiologist in the city, got the angiography done. At this moment of time, a Lima graft is patent, LEDs as usual occluded, LCX occluded, and the RCA is having a diffuse disease, diffuse ISR, and she was on all the therapies, all anti-anginals, still having chest pain. And then she landed up in my center. I did the angiography, the Lima was patent, and now on echocardiography, her ejection fraction was 45% with anterolateral wall hypokinesia. So I decided to wire the LCX first. I took EBU 3.5 6 catheter, took an intermediate wire, wired the lesion, and then I did cedar pre-dilatation with non-compliant balloon. It was done from distal to the proximal side. As you can see, the vessel. More bed preparation was done distally, and then a drug-coated balloon with a thought process that the drug should be changed. So it was a paclitaxel coated balloon. 3 balloons were placed, and during the placement of these balloons, I could get that at some point the overlap was not so good. And I explained that to the patient party upfront that she may have some chest pain. So whenever she have, please inform me. So story don't end over here.
We have to be little quick.
Yes, sir. After 1 month, again she had chest pain, class 2 angina. There was a focal in-stent restenosis. This time, the plan was to do a drug-coated balloon. It was done. And as you can see over here, see after cedar pre-dilatation with NC balloon, the drug-coated balloon, the same drug-coated balloon was done, and you can see the result. The LCX is flowing well. The vessel, the distal vessel has grown, and in this setting, the POVA was done to the RCA from proximal to the distal end with the NC balloon. As due to financial reason, the patient could not afford the drug-coated balloon at this moment of time, so the POVA was done. So the takeaway message is in-stent restenosis can occur due to mechanical factors, patient factor, as well as the drug factor. In-stent restenosis total occlusion lesion are softer as compared to chronic total occlusion lesion. Drug-coated balloon are better placed as compared to placing an additional layer of stent. Drug therapy should be individualized with attention towards reaching target goals of lipids as well as use of anticoagulants and emergency. In this patient, I got homocysteine levels done, HSCRP levels done, and lipoprotein A levels done. Everything was high. So I put the patient on apixaban, ticagrelor and nicosprin for 1 month, and at the same time I added colchicine 0.5 mg once a day. And apart from that, I added statin full dose plus bempedoic acid. My goal was to reach a target of less than 50 mg per deciliter of LDL, which was achieved. Patient is doing well. Now it's 6 months. The patient is doing well. The plan is to get an angiography in the month of April because of her insurance issues and all, and then the plan is to do the RCA with a drug-coated balloon after an IVUS study. Thank you.
I want to differ regarding one point. Whenever dealing with repeated episode of stent failure, intravascular imaging is a must, not wherever available or whenever available. We have to image it like that.
Sir, imaging guided thing is planned, so that is why, sir, I only opened the LCX and the RCS planned.
LCS also had target stent failure.
I very well agree with you, sir, but in my hospital it was not available. The patient has gone to all the cardiologists and the CTVS surgeons. She was
There is no
refused.
excuse for that. You have to have it imaged.
So in the next settings, it is planned to get an IVUS done and then to move forward for
So if the
us.
patient was following up only with you, what would you have done differently? She didn't go anywhere else. She just came to you with an LED restenosis. What would you have done differently?
Sir, I would have opened that LED restenosis with a drug-coated balloon in the first point itself, sir. After an imaging study, sir. Without imaging study, I would have not approached. In the first setup, sir, if I have got at my center, sir.
Thank you very much.
Thank you.
What you would have done in surgery, what you would have done in that seat portion.
Based on see why she's standing up with all this stuff. I would also need to see how bad the circumflex and the RCA lesions are. So if I can't find an under expansion with just prolific restenosis, I will send it for surgery with grafts to all vessels, not just one vessel.
The imaging.
We could move on to the next case. The interesting case of unknown stab and reperfusion in stage CT. Dr. Manoj Shri.
Good evening, everyone. I'm Dr. Manoj. I'm here to present an interesting case of unknown stab and reperfusion in stage CT. Here is my patient, a 40 years male, who presented with this STEMI infraposterior wall limit, window period of 6 hours. He is now case of hypertension and diabetes. As the patient, we had a check angio, which showed that the major OM is being uploaded, and we did a primary PCA to LCS to major OM angio. And we planned for an stage RCA to CT, which had multiple complications with perforation, dissection, and with the classical techniques, we techniques, we saved the patient. So firstly, for initial, at the time of the primary, we took a sound French J 3.5, wired the L6 and OM, and pre-dilated the OM lesion. So here we can see there is a retrograde RCA has been filling. The short segment of CTO is there. So after the OM has been pre-dilated, there is a recurrent OM has been closing de-occlusion and recoiling of the vessel is there. So what I did is just took a dilating stent 2.75 into 36 millimeter, deployed it normal, and post-dilated with 275 and post-dilated with 275 and yes, sir. So next, after the 3 days after that, we planned for stage the RCA to CTO, where we took a sound JR 3.5, and careful wire escalation has been done with first start with whisper, then filling with XTR, then Gaia. But we are not able to cross the CTO lesion. So I just parked the wire at the side branch. So then I took with the Conquest Pro 2 with the fine cross essence support. So with the careful drilling technique, then I am able to cross the CTO lesion, and after the crossing the CTO, the lesion, I am able to go easily in the RCA. So after that point, some point I felt the resistance and just took out the guide wire. So with the guide wire, I just checked with the micro catheter, and I found that I'm in the false lumen. So what I did is I took an opposite side puncture and then went and check shot whether where is the lesion at all. So this is where I can find that I am in the false lumen. In the check shot I can see, just in the check shot I can see there is a large perforation of the distal RCA. So on the next shot from the microcatheter, again I can see that the distal RCA has been closed. Distal RCA has been closed and that's the perforation is there. So what I checked it, the distal RCA has been completely occluded and the perforation is still persisting. So already I kept the microcatheter inside. So I took the cyan blue and then I just crossed with the CM loop and just went inside the distal part of in the true lumen. I just found the true lumen and just entered into the true lumen. So after with the fine cross, I just crossed the perforation part and just placed the CM blue wire in the distal part of the PDA. First, actually, I thought that this is a PDA and just entered into that and just placed it. And after taking the fine cross, I just entered into. I took a 2x10 balloon and just uploaded for 2 to 3 minutes. And at the time, I checked for an echocardiogram. Echocardiogram showed there is no pericardial effusion. So because it is a type 2, it is only just externalization. And there was no pericardial effusion. The patient, there was a slight drop in the BP. Otherwise, patient is comfortable. So what I did is I thought that everything is after the occlusion, distal part of the perforation is being closed. So next what we did is first initially this part the proximal RCA has been stented. So I stented with 275 48 mm of long stent, and I just because it was the decision is extending down, I took long one and I just completed it. After this, I just reviewed the shots and I thought that finally, because in the previous shot, in this we can see that I have missed that the PDA is already closed here. So I thought this is a PDA, but the PDA has been already previously occluded because of the previous perforation of the thrombus there. So what I did is I just took a field XTR wire with the balloon support and I just entered into the PDA. I just made a dotting. I didn't do a balloon dilatation, just did a dotting, and I able to open the PDA. Here I can see the PDA is being nicely opened, and the CM blue is already in the PLB branch. So after that, what we did is actually that is I can see that there is an ambiguous lesion over the distance of the stent. So what I did is, I don't want to take another risk because already the patient had two more complications. I don't want this, and I stented with the 2.75 24 mm stent. So after that, I thought that everything is fine, and I took a pre-dilatation, post-dilatation was done adequately, and the flow is good, immediately flow. Patient is also comfortable, BP is improved. So I thought that everything is okay. And then I took the wire and final check shot showed there is a distal perforation in the PDA. So I thought that I had another thing. So I just took the CM loop, just crossed the lesion. So I did a balloon occlusion. I took a 2x10 balloon and occluded for 20 minutes. And because I just checked the ACT during this procedure. So ACT is comfortable with the 230 seconds. So final check shot showed this one. So take we have to keep the optimum ACT during the procedure. Multiple views to detect the perforation. Serial echo is needed to detect the pericardial effusion. So we have to start with the workhorse wire, then we have to excavate, and we have to confine the wire to the true lumen, and always we have to monitor the distress. And if we have add a imaging, that will be very helpful. Thank you, sir.
Not a straightforward CTO. So in the beginning itself, you should have started with the contraindication, not later on during the procedure when you face the complication.
Yes, sir.
That is a big time.
Yes, sir.
The famous cardiologist Dr. Samuel Matthew says, you should know when to stop the procedure and call it a day. I don't know what complications you made, and I have not understood how the hell you got out of it. You're perforating left, right, and center. You've got reason flows. Why are you chasing the PDA when your patient is alive, all right, and the RCA is going well? Stop it and come out. Do another day if you want to be so adventurous. We just took it sheer lucky. If the PDA thing had not controlled properly, for this.
Dr. Rishi Bhargav, complication in CTO.
Good evening, everyone. I would like to thank India Life for giving me this opportunity. The patient I am presenting today is a 56-year-old male. He presented to us with ECS and STEMI. In ECG, there were T inversions in anterior leads. PTCA to LED we did, and after that, after 2 days of the procedure, we have taken patient for RCA intervention. The ejection fraction was 35% with global LV hypokinesia. So this was the RCA anatomy. So we have decided to intervene this. Upfront we have taken dual injections. It was showing some collaterals, epicardial as well as septal. So we have planned to start with antegrade wire escalation and then if not possible, maybe orthotic. So after trying some workhorse wire, I switched to cross 800. With balloon support, I could advance somewhat, but it was going into one of the collateral branch only. So I withdrew it and then went to another channel. And when the shoot was taken, this has happened. So this was a large dissection with a large intramural hematoma. So this was the situation. I have a total occlusion at the ostium proximally and then a big dissection segment with big intramural hematoma. Because of this, I was facing two problems. First, patient who was relatively stable on presentation to my cath lab was having some chest pain now, and the collaterals which I could see are now vanished. However, that also provided some information. First, now I know that the total occlusion segment is small, and second thing, I may not be having the total collaterals, but now I have RCA anatomy map, so I know where I have to forward it. So I knew my wire is going to go to the false lumen. So the way we do knuckle, so I decided that I will advance the wire, which should be suitable for knuckling. And if at all it couldn't knuckle, because while knuckling we generally don't have this bigger internal hematoma, I will keep that wire as an anchor because I don't have anything else to anchor. So I will keep that as an anchor, and at the same time I will try to take another wire to enter into the true lumen. And fortunately that happened. I could access the true lumen. Another wire could go to the true lumen, and I parked it distally, and then with the help of catheter, shoots and balloon, I could confirm that. You can see that balloon dottering and easily without any resistance going to distal segment. And this leading to resolution of internal hematoma. And this is the shoot after accessing the true lumen. So after that, I stented throughout the RCA up to ostium, then flaring of the ostial segment is done. And this was the final shoot. So patient improved after that, there was no chest pain, ejection fraction improved to 45 to 50%. So take home message for my case, plan before the procedure and plan as you proceed, because you never know what complications can happen on your way. Not to lose right catheter access in case of proximal dissections. Entry into the true lumen can be achieved by either hairpin bend technique or air-milling the wire with right catheter engaged non-selectively. It is better to ensure complete resolution of internal hematoma during procedure, which otherwise can progress angi-wise to tapered vessel. Thank you.
You are lucky you could gain access to a tool with the same guide. You have to change the XLD, see and pass, but good we are able to solve it.
Of all the cases done so far, this is the most doable case. Well, very well done, no adventures, straightforward. Only that when you are not sure whether it is a true lumen or a false lumen, please don't pose direct too much and create extra opportunity. Thank you.
Thank you. I will invite Dr. Arun Gopi to discuss crash in a difficult terrain without ideal simple PCI turned into an ICU.
Respected Chair, friends, warm good evening. So, the story is of a 65-year-old diabetic hypertensive for the last 5 years, CKD with a EGFR of 30. Inferior alignment for which underwent PCI about in 2014. Present with progressive foot angina, had recent anterior autonomous elevation MI with recurrent rest angina. Echo showed wall motion in the elevator preserved LV function. Underwent an angio in outside center, had patent LC extent but died calcific stenosis in LED and RCA. As in most of these centers, they go with multiple opinions. The doctor itself is a doctor, and they get opinion even from their friends in US. So they come up with a plan of rotablation with IVL, has to be image guided with minimal contrast PCA. So this is of a patient diabetic hypertensive CKD, type calcific stenosis in LAD and RCA for an IVS guided minimal contrast rota PCA with obviously an IVL backup. So this is we didn't have the shoots from the outside, so we take 2 shots. So you can see the type calcific stenosis in the LAD and RCA planned for rota. So obviously the temporary backup pacing is inserted. Fluoroscopically calcium is well visible. We have the IVL backup setup, and we plan for an IVS guided minimal contrast rota PCI. So right femoral arterial axis femoral vein for the temporary pacemaker, heparin 7500 in, EBU 3.57 French. We have a BMW wire in the distal lady part. We wanted to image first. The IVS catheter couldn't cross this heavily calcified area. We exchange over a caravel to a Grand Slam wire for extra support, and we still couldn't pass the IVS, so we just have a 2 into 12 new balloon, inflated 10 atmospheres just to create a passage for the IVS catheter, because we also thought we'll get an imaging done first. So till now no contrast checks were done because the patient had CKD, and we wanted to do a minimal contrast rota PCA. So till here everything was fine. Suddenly a patient develops severe angina. We find ST elevation and patient developing VF in fraction of seconds, and she's defibrillated. He was defibrillated, and we start CPR. So the temporary pacing was unfortunately there, so he gets on temporary pacing, and we take a check shoot to find this horrifying view. So it's thrombus everywhere. So possibilities in such a scenario: either the sister forgot and what she gave as heparin was not heparin. It could even be a guide-induced LMCA dissection. There could be heparin resistance, or it could be a predilatation balloon had an occult rupture. So all these possibilities in the back of the mind. So our team gets activated. The anesthetist takes care of the CPR as well as the intubation. So you can see there is no cardiac contraction at all. On CPR, this is a use in between CPR. We quickly try to restore flow. We have a 2.512 balloon daughter to LAD, and we quickly wire LCX, the flowing vessel. We wire LCX again, 2.512 balloon daughter into LCX and dilated. Still no recovery. We give intracoronary epinephrine, which is a lifesaver in all these scenarios. The sister informs us that the ACT is 284, so it's not heparin resistance or inadequate anticoagulation. We ask them to recheck the ACT again. Now with the epinephrine, there is some cardiac contraction coming back, but still there is no improvement of flow at all. We give intracoronary tirofiban, multiple thrombosuctions done to LAD and L6. There is some blood pressure coming up by now, but still we don't have any flow. We continue to do balloon dilatations, 2.75 non-compliant balloon and 18 atmospheres. We get some flow, but repeatedly patient goes in for VT. We check the ACT again, it's 320, so it's not because of inadequate anticoagulation. Patient by this time, you can see the LV is hardly contracting, there is no flow. You can't, obviously our plan of rota gets behind. We improve flow. These are flows when epinephrine is given. That's only time when there is flow and some contraction. We need to be very clear that since there were recurrent episodes of VT, we need to track the stent down. But that calcified specule would not allow stent to get tracked. We put a buddy wire. We couldn't track the stent down. We had wire in the L6, we used as an anchor. Still we couldn't track the stent down. We balloon dilated again. They did a 3 and 15 balloon. Still we couldn't track that. We had a guide plus down, a guide plus EL down to increase support. We tried passing cutting balloon, neither stent, guide plus or cutting balloon, nothing crosses the mid segment. And we could pass the balloon. That was the only thing that could pass down this long dissected LAD, and he was going in for recurrent VT. And this was not a scenario where he could rotablate. And fortunately, we look at that we have at least had a backup of IVL there. So we quickly get the IVL down through the guide extension. 312 IVL is tracked down the guide plus 4 cycles given at that site. You can find a dog boarding, but it disappears. In this process, you can find even the IVL ruptures. So in fact, there is an unintentional granuloplasty effect from the IVL rupture. Because after that, things all become smooth. You are now able to track a 3.548 DES from LMCA to LAD. Already the L6 is wire protected. So this unintentional granuloplasty from the IVL actually ensures good stent expansion. There is no waste for 348 stent. We have TB3 flow in LAD and L6. Patient improves. There is a geographical miss of distal LAD, which is tended to the 315 drug-eluting stent at 14 atmospheres, and we dilate the overlapping segment. And we do the final formalities. We do an LMCA pod with 410 balloon. LED is adequately post-dilated 3.5, non-compliant in 18 atmospheres. And this is the final angiographic outcome. About 90 ml contrast needed to be used despite being CKD. We put the patient on ticagrelor and aspirin for 1 year. Creatinine increased as expected after the procedure, but stabilized over 1 week's time. Patient was non-oliguric and was discharged on day 5. Is doing good on clinical follow-up, currently asymptomatic and creatinine stable. So why the whole problem of thrombus happened all over, we were not still very sure. We had good ACT, so neither it was inadequate anticoagulation or heparin resistance. A guide-induced LMCA dissection was also not a possibility because after we had restored flow, we could clearly see that everything was fine. The pre-dilatation balloon we had checked, but we didn't find anything there. Looking back, in these cases, what happens when we do with zero contrast PCA is we actually forget to check we allow the guide to back bleed. Sometimes thrombus gets in the guide. Here, actually, when the balloon was not crossing, if you have put an IVUS, it would have sometimes given us more insights. And upfront rota in these cases always gives us this rota regret. If you had passed a rota upfront, it could have sometimes been useful. IVL granuloplasty was a savior in this case. IVL always has been bailed out in some scenarios. Granuloplasty is an intentional technique used in CTOs, but here in our scenario, an IVL granuloplasty was a savior. To conclude, having an IVL backup for all calcified cases definitely is useful. Diffuse calcific stenosis and you have a crashing patient, IVL is the only bailout strategy which helps you to get the stent down. It was an unintentional granuloplasty with IVL, but it was very effective blood filtration, and it's better always to double check heparin when you're doing zero contrast PCA and always closely monitor and back bleed your guides. So to conclude, in a difficult calcific terrain, obviously your backup IVL becomes your bailout. Thank you.
Really good salvage. In case you did not have an IVL here,
That's what
we
I
have
might
gone
say.
for a rota or
Rota,
in that situation.
yeah, if you don't have, but see, LV is hardly contracting, there is no flow down. By all practical purposes, this is absolute contraindication for rota. So that's why I said in these scenarios, short of IVL, nothing would have worked because the cutting balloon was not going down, or dialysis was hinged on the side, no stent was tracking, anchor balloon didn't work, body wear didn't work.
You could have deployed the first stent till where it went. To that stent you could have
Because
the guideliner and
Yeah,
then
guideliner-
probably it would have gone through that.
The guideline was almost in the middle lane. The calcified specule will not allow even guideline anything to go across. So guideline already was middle lane, so there was no point of sending the proximal lane.
IVL was, the pulses were not delivered or we just.
It delivered 4 pulses, and the 4th pulse it ruptured. When the log boning was going to give away, it ruptured.
But
So it was
then-
typically a calcific specule.
But then it is not very high pressure. Is it really granuloplasty?
No, it is an unintentional granuloplasty. IVL actually it inflated at 4 atmospheres, but the pressure that IVL generates is close to almost 55 atmospheres. So that's why when it ruptures, it's almost like it's an granuloplasty.
So initially was the virus or N virus or?
Yeah, the virus and so the obviously
Sometimes
complex
when we
case,
use
yeah.
ox virus, we see the clotting coming off and
No,
thrombosis.
this was anyway a complex case. A doctor's father gave you. Obviously, it's an environment.
Established case, Arun, there is a syndrome called California Brother. You should just read that up. That's probably what happened. Excellently well managed, fabulous presence of mind, especially salvaging the situation with the IVL. I think that was very, very well done. But I got one point to make: with your experience and hand skills, you are excluded from the competition.
Thank you. Thank you.
Thank you. The last presenter, please come on that. Dr. Bharat Kumar, longitudinal stent deformation in unprotected LMC.
Yeah, good evening, friends. Thanks India Life for this opportunity. So our patient is a 50 years male who is a diabetic hypertension and dyslipidemia who had a recent annual MI and was traumatized with connector plates. He had LV dysfunction with a case of 40%. Hemoglobin and renal parameters was normal and this is the ECG. Then I took him for a coronary angiogram. It showed left dominant circulation and L6 is normal. This is a non-dominant RCA. And the patient had proximal to mid-late junction. He had a critical 90% stenosis, and he had a distal LMC stenosis also. This is the distal LM which showed 50 to 60% stenosis. In order to quantify the distal LM significance, I did IVUS before stenting, and this is the IVUS study showed significant mid-areal deletion, and this is the distal LM segment which showed a significant block burden of around 66%. So this I am planning so I am planning to stent LMC and LAD also. So what I did initially is I initially stented the proximal to mid-areal segment with the synergy 2.5 to 48 millimeter stent, and this is covering from proximal to mid-areal coronary lesion. And subsequently I stented the LM proximal LAD disease, this one using the synergy 4x28 stent. Then I pushed the same, I am dilating that with the nominal pressures only. Then I pushed the same stent balloon across the overlap segment at nominal pressures and dilated this overlap segment also. Then I pulled this same balloon to flare up the ostium. So after flaring up the ostium, I am not able to get back, able to pull back the stent balloon. It got stuck actually. I am finding it difficulty in resistance because all this I went it through the radial approach only. So there is severe radial spasm is there, and with so much difficulties in spite of repetitive negative pressures in the inflator, I somehow pulled the stent balloon. But after this, I realized that whole guides came out and the guide wires also came out. I found out that the stent got the proximal LM LAD stent got stretched into the aorta. So this is the stent boost which is showing. This is the distal LAD stent, and this one is the LM LAD stent, proximal LM LAD stent, and this is the stretched deformed stent parts which is hanging in the aorta. So what we have to do next? This is a fully deployed stent with a stent deformation with the partial stent just hanging around the aorta. Around 4 to 8 stents are hanging in the aorta. So what we did is we cannot snare it because there is high chances of avulsion and it may end up in a catastrophe. So what I did is again I re-engage with the EDU and enter the LMC via the side struts, and we have to create the new ostium through serial dilatation with 1.25 and 1.5 and 2 balloons. I created the new ostium of the LMCA, and I stented the LM with another synergy 4 into 32 millimeter stent, a slightly lengthier stent when compared to the previous one. This is mainly done to avoid this deformed metallic scaffold obstructing the LMCA. So after this routine part was done and we get the good results, except that we are having 2 metallic covers in the LMCA, and the L6 flow is also good. So post procedure I did IVUS run to the LM LAD. It showed very good apposition with good luminal gain, and there is no block shift in the ostial LCX. And this is the echocardiogram of the patient which shows this is short axis view, which shows that this is the partially hanging struts, deformed struts in the aorta. Below that is the true ostial LMCA lumen, which is well away from the hanging struts. So this longitudinal stent deformation is a rare but life-threatening complication in PCI. There are many mechanisms for this, like entry or exit of additional devices like guide wires or guide extension catheters or balloons may cause this longitudinal stent deformation. In our case, it is the forced retraction of the partially deflated stuck balloon, that is stuck stent balloon, which acts as a surrogate culprit in our case. Its recognition is very clinically important to avoid mortality. And the thinner struts with a lesser number of connectors are more vulnerable for longitudinal stent deformation. So in order to prevent this, we need some dedicated LMCA stent, like with more crowns, which provides external, which provides excellent radial strength, may prevent this longitudinal stent deformation. Thank you.
First thing, that is LM to LAD, and then what was the size? LM. I mean, it was LM to LAD. That was the size? 4. Then did you do a odd clot in the LM or just try to flare the ostium?
Yeah, I flag the ostium.
Because there is a problem. So this we find very often. So when you stent from LM to LED, the LM stent is not well opposed. So when you pull out the balloon, the stent can be deformed. Second, you may not completely deflate the balloon. You may not wait enough. So when in a hurry, without deflating the balloon completely, when you try to pull out, the stent can be pulled back. Second, this is only a 4 mm balloon. So how can you flare properly with this balloon? So LM ostium cannot be flared properly. So I think it is only a myth to LM to LED stent, that balloon, when you pull back and flare, the flaring is not proper. First you have to do a port, then probably you can think of flaring.
What size of the stent you put in LED, proximal LED?
LM88.
Proximal LED had a stent.
2.5.
Yeah, 2.5.
2.5. You did it, I was in the proximal LED.
Yes.
2.5 proximal LED is unbelievably small.
It's actually around the 3, sir. But distal sizing, I took the stent with the distal sizing. Distal it is 1.5.
It was directed in later.
Yes, sir.
Do you think the studs hanging in the aorta can cause any problems? How many days is the procedure?
2 months. Still I am following it up.
I've seen many patients, 3-4 studs hanging, don't cause anything. Okay, I think we have come to the end of this session. Thank you so much.
The next session is my worst nightmares, 6 plus 2 minutes. The chairpersons for this case presentation session 32 are Mahesh Basrige, Ajay Swami, Mridanga Shekhar Chari. And the discussants for this case presentation session 32 are Parnish Arora, Mahesh Kushwaha, Rajesh Badani.
Yeah, it is mine. I am recording it. No problem.
So we are going to start this case presentation session. First is a fortnight lecture, RTS, otherwise surveys, will be given by Preeti Sharma.
the outset, I want to thank Indian Life for giving me this opportunity, and I'll be speaking on management of retroperitoneal hematoma. So we know that retroperitoneal hematoma is the result of blood loss due to the injury of parenchymal tissue or vascular structures within the retroperitoneal cavity. And etiology can be traumatic, spontaneous, or iatrogenic. Iatrogenic retroperitoneal hematomas are the result of PCIs or endovascular procedures, which interest us the most. And the good news is that the rate of PCI-associated retroperitoneal hematomas are on decline, but when it happens, your patient is at increased risk of morbidity and mortality. Spontaneous RPH, we do encounter, but it is a relatively rare clinical condition. The diagnosis is more common in elderly patients, patients who are receiving anticoagulation, and those with an underlying coagulopathy. So, first, I want to tell everybody here that the good femoral access at the closure technique is the key to prevent retroperitoneal hematoma. And we should all be aware of this common femoral anatomy. We divide it into the 5 zones, and the zone 1 is a dangerous zone where your inferior epigastric artery is. If you advertently puncture at this site, you might get, this is a high puncture, and you might get retroperitoneal hematoma. And zone 5 is bifurcation. If you puncture at this site, you might get pseudoaneurysms because of incomplete compression. And the best practices for femoral access are, if you're planning a tower, just look at the CT, choose your site properly. When you decide about the site, about the access, just when you are in cath lab, mark your femoral head with some marker, and then use an ultrasound guided puncture. And once you put a sheet, take a check shoot before you give them full anticoagulation. And this is ultrasound guided puncture. I don't want to go in detail. And some people prefer micro punctures, but in some studies this was found to be associated with increased risk of bleeding complications. And good vascular closure, we all know ProGlide based strategy, either you use 2 ProGlides or a hybrid strategy with the ProGlide and angiography will give you a good perfect vascular closure. And before taking your safety wire out, you should take a shoot just to see that you have closed the site properly. So, how does a patient presents? You have done a procedure, you have shifted this patient to CCU, and your patient, you get a call that the patient is having abdominal pain or a back pain, and now is having hypotension and tachycardia. So this is the sign of alert. You should take this patient immediately to the cath lab and check with the DSA of the groin vessels. And as I told you, the physical examination is commonly non-diagnostic, and if you are relying on an ultrasound, more often you get fooled by an ultrasound which doesn't show you anything. And the mainstay of diagnosis for RPH is a contrast-enhanced CT scan. So this is a CT. I want to show you. This is the RPH in the left perirenal space. You can see the mixed density of the blood, and this is the active breather you can see in the left perirenal space. And once you are in cath lab, you have this kind of complication. This is a dented bladder sign. You can get the bladder get compressed because of accumulated blood, and you get this sign. Normally you see the bladder looks like this. So this is the algorithm. You're suspecting a retroperitoneal hematoma. Your patient is having hypertension. You all have to do general measures for bleeding. Obtain a large IV or central venous access, and give normal saline administration, and then you have to send blood for typing and cross-matching to hemoglobin measurement. But in initial state, you might find that the hemoglobin is, it doesn't show up that it is going low, so you have to do a repeat hemoglobin measurements. And so it depends on where your patient is. If the patient is in cath lab, is having hypertension, and you're suspecting, you can just check a bladder fluoroscopy. And if you don't have a contralateral access, take a contralateral access and do a DSA. And if you find out that there is an active bleeding for large vessels, a covered stent, balloon occlusion followed by a covered stent, and for small vessels, coiling might help. If both of these don't help, you have to take help of a vascular surgeon. Outside the cath lab, if a patient is hemodynamically stable, send this patient for a CT scan. If there is a RPH without active bleeding, you have to manage them conservatively. With active bleeding, you have to shift this patient to cath lab. So bleeding from groin vessels, there are 2 main types of iliofemoral perforations: large vessel perforation, or small vessels like inferior epigastric or lateral circumflex iliac arteries. So prior to pursuing definitive treatment, a balloon is inflated at low pressure over the size of perforation to stop ongoing bleeding. So covered stent, self-expanding stents are preferable at the common femoral site because they are more resistant to deformation during flexion. These are the stents, self-expanding stent. You have Viabam, Covara, and BART fluency stent available. And these are the balloon expandable stents. This is the B graph which goes through a 6F. So I'll take you through a case. This was a 71-year-old male who presented with ACS in the ER. They had put an arterial and venous line. We did a procedure through right radial route, and we did a L6 stent in this patient. After 24 hours of observation, he was shifted to ward. But on walking, he complained of pain in leg. Urgent Warren Doppler was done, and which could show a pseudoaneurysm along with a large abdominal collection. He was urgently shifted to cath lab, but in the meantime, he developed hypotension. So lots of fluid. We had put a 8F sheath in the groin, left groin, and take a check shoot, because actually, if you look carefully, there is a perforation at a CFA and profunda junction. We did a 820 balloon proximal balloon inflation. And then when it failed, we had put a Covera plus 9 into 100 millimeter covered stent. This was another patient when we started tower program at our center. This was an obese lady. We did a fluoro-guided puncture, and this was a tower 27.5 myval was deployed. Pro-glide closure was done. As I mentioned, the safety wire was removed, and after that, when we take a check shoot, you can see there is a large perforation. Patient collapsed on the table, and the BP was going down. From the right axis, luckily we had the right axis, we inflated this 840 balloon at the site and took a 10 into 80 fluency plus covered stent, and you can see that we are deploying this stent, looking carefully, staying away from the bifurcation, and this actually sealed the perforation. Now for small vessels, you can use coil, and for very distal perforations, one can use a cyanoacrylate glue or thrombin, but be careful that you have to avoid leakage of the sealant outside the perforated vessel. And alternatively, you can do a prolonged balloon inflation or put a covered stent across the origin of a perforated vessel, which may achieve hemostasis. These are the coil which are available from Chiramo or Cook. You can use this for small vessel perforation. And if nothing works, you can take help of your vascular surgeon. But mind you, it doesn't work in most of the patients because they are fully anticoagulated and nobody wants to work on these patients. So my take-home message from this talk is that the key is prevention. We all should learn good femoral access and closure techniques. And if you are doing a tower CT analysis, look at yourself, just choose your site carefully and just have a bailout planning. Have the right equipment available and know your stuff. At the time of emergency, when you're running around, that's the worst scenario. And you should have a high index of suspicion. If you have a suspicion, shift this patient to cath lab, take an access and take a DSA. And if you have a bleeder, just manage active bleeding and you can save your patient's life. Thank you.
How old was the patient?
This was a 70. So the tower patient was a 66-year-old female. Her BMI was 40, and the male in whom it had pseudoaneurysm and abdominal collection. He was a 71-year-old male.
In overall clinical situation, what number of patients need all this covered stent, and what is the rapid way to diagnose retroperitoneal event? Because every patient not being immediately accessible to CT scan. I mean, a lot of us, our own colleagues, work in a single specialty hospital where CT facilities are not available.
So that I mentioned it because in my career of intervention cardiologist, so far we have 6 RPH, and 3 of them we could diagnose, and we took them to cath lab, and balloon occlusion didn't work. We had to put a covered stent. One patient, because she had PCI which was late in hours, and the doctor on duty was not well versed. He just got an ultrasound, and we were fooled by the ultrasound. Ultrasoundologist said that there is hypotension because of any other cause. There is no blood in the abdomen or in the groin. I don't see anything, any leak. But when we shifted this patient after 4 hours, we could see a large RPH on CT scan. So sometimes, so the best tool I would say when everybody is working, just come back to the CCU, take this patient to cath lab and take shoot from the your contralateral groin. I think that will set the, because in 2 patients we took a shoot and we screened from the lumbar arteries to the groin. We could not find any bleeder. By the time the heparin effect was gone, the bleeder was gone. So we did not find any active bleeding, and luckily we could manage these patients conservatively. So in 2 patients we could do a conservative management because there was no active bleeding from any other side.
The important findings in ultrasound is, you cannot find the blood, but the hypotension is because of the third space fluid loss. So a lot of, if you see the perinephric spaces or space around the liver, even if you see, say, 1 centimeter, then almost like 1.5 to 2 liter of fluid loss. And in our practice, I mean, majority of the peterborough hematomas we are diagnosing by ultrasound, and we are doing necessary steps. And for routine angioplasty cases, whether I mean the sheath is in or out, it's being removed or not, these are all important factors probably we have to look in. Tower, any of people who do tower, they are well versed, everything is kept ready because this is a normal.
In last case, you use a contralateral equipment. Suppose in our cases, best thing is hybrid procedure because you always have one safety wire from contralateral side. Instead of putting the cover stent, because cover stent is not a good thing long term. What we can do, we can take 8 by 40 millimeter balloon. You do compression from inside. From outside, you do the external compression from hand. In 5 to 10 minutes, once the apparent is neutralized, 99-100% case it will see. But you put cover. But you put cover.
No, we took a 840 balloon.
Yeah.
It was inflated there. We waited, and then when it could not seal the perforation, then only we had put a cover.
But you have to reverse the heparin.
So when you have such a hardware, you cannot fully reverse the heparin. So that is the
because
catch.
procedure is over. Once procedure is over, you can heparin. No problem.
You have balloon in the femoral, you have heart sheaths there. So yeah. So yeah. So you cannot fully. So that's my point. This was in the flow chart that you reverse the heparin. But if you are doing a procedure, you cannot fully reverse the heparin. But if you see that you are done with the procedure, there is a small bleeder, you can try with the reversing heparin, because with this small bleeds, mostly you can get away with when your heparin effect is gone.
Just a comment. As far as ultrasound is concerned, it is not a modality of choice for diagnosing retroperitoneal hemorrhage, because it is a retroperitoneal space. You cannot diagnose by doing ultrasound. And if you know, blood is when it is get collected, it is going to be homogeneous, and you will get lot of echoes from there, and you will not get any collection in the abdominal cavity because it is retroperitoneal. It is not inside the peritoneum. So ultrasound is not a modality for checking whether your patient has got a retroperitoneal hemorrhage or not.
If the hospital doesn't have CT scan, what do you do?
Clinically, you have to give. The modality is not going to give you any clue. So why you are going to use that modality?
No, we would definitely disagree that. I mean, a good ultrasonographer definitely can pick up the retroperitoneal fluid. I mean, peripheral spaces around the liver, and most of our bleeding we have diagnosed on ultrasound only. Till now, we have almost done 75,000 procedures, but not a single case we have sent the patient for CT scan. Because this is particularly very important in a single specialty hospital where CT facilities are not there. Then we do an angio from contralateral side and just do the whatever necessary so needful. The hypotension is not because of blood loss. The hypotension is because of the third fluid space loss.
You are absolutely fine.
When we see the fall in hemoglobin, it will not be that great. The PCV becomes less. I mean, in centers where most of us would agree that in big hospital where all facilities are there, it is very easy to take the patient to a CT scan. But I don't think from the everyone from this we can take a word that how many patients do CT scan immediately if the patient gets hypertension.
So if a patient is stable, then only you are sending it. In the flow chart, it was mentioned that if your patient is hemodynamically stable, then you are sending this patient to CT scan, and if you find an active bleeder, shift this patient to cath lab. No active bleeding is spontaneous, you just do a conservative. Sir, we are here to learn best practices. So the message is clear that if you want to see for a RPH, CT scan is the it is a tool of choice to diagnose RPH. We ourselves have, like in my case, one of my case, I have got fooled by ultrasound, and that was done by the HOD radiology in the middle of the night, and he was confident that there is no blood in the abdomen. But once we got the CT after 2 hours, because I was suspecting, I could not shift that patient. After that, once we took her to cath lab, the time was gone and we could not save her life. So the best practice is, as we mentioned, hemodynamically unstable patients, shift to cath lab, do an ultrasound. I'm not saying that ultrasound is not going to help you, it might help you. But once you see on this groin vessel DSA that there is no active bleeding, you can be at peace. And if you find an active bleeding, just go and treat that. That's the way you can save the life. If a patient is stable, then only do a CT scan. Unstable patient, we are not sending for the CT scans. The best way is to take these patients to cath lab.
You can take the next please.
How often you have to use the surgical intervention for the liver?
Then the situation is even worse. Then it is very difficult, and then no surgeon would be willing to operate in these patients. And most of the time, by the time you get a surgeon and you get these things done, you cannot save these lives. So you have to be ready with all your equipment to save their life if you are doing a femoral access, and learn how to do a good femoral access and closure.
Surgical mortality is very high. And so,
Surgery
since we are going
is
late,
very
we will have to reduce the discussion time. So I would like to call upon Fisal Semina to present her case. Seat gone into disarray. Fisal Semina. Public absent. Then Venkata Krishnan Ramakumar to present 15 minutes of madness.
Good evening, everyone. So we took up a 53-year-old female for primary PCI. She had an angiovalomite, suffering chest pain, rapidly deteriorating hemodynamics for the last 15 minutes. Normal sinus rhythm, echo showing EF of 40%, diabetic, hypertensive. She had severe financial issues. Actually, it was a social admission. It was a maid of one of our team members. So we decided to take her up for primary PCI. The angio here showing expectedly a significant LAD disease. There's a long left main. There's some TIMI1 flow distally in the LAD. There's a significant size mismatch between the left main and LAD. The circ ostium looks mildly diseased over here, but the rest of the circ is normal. Better views of the cranium here to define the LAD, and we can also see that there is a borderline long segment disease of the right, which could be significant later on. Just images to help understand these things better. So we had a decision to make. Now, do we plan the whole thing in a complex way and take into account all these considerations, or remember it's a primary PCI, keep it simple, quick in, quick out, and then finish out and come out established treatment. So initially we chosen the latter. So right radial 6F EBU run through. We dilated with the 2512. Dilated up to the LAD ostium only. There was some slow flow even after nicorandil. We looked at these shots and we thought, okay, I don't think we can nail anything here. We'll have to come back to the left main. So we went ahead and aggressively pre-dilated the distal left main LAD ostium complex with the 3 balloon. There's some dissection there that we can see. Now to try and conserve finances, we thought mistakenly in retrospect that we can get away with one stent. So we took a 3530 ZDS. Immediately after deployment, BP went down, ECG changes, chest pain. We lost both diagonals and there was a massive spiral dissection, as you can see there. So next step, we immediately tried to just put a wire in the diagonal, try to POBA and establish some flow, which we did. Now you can see on the extreme right over there that we were in deep trouble in this case. What happened was when we tried to put a second stent in to plaster the distal dissection in, the stent just a few millimeters beyond the guide would not go in, and after a point fractured. And we tried to pull it back a little bit, and then we were trying to handle that situation. But immediately after, patient went into bradycardia, arrest, CPR, and then we lost all access over there. The stent is hanging in the axillary artery with the guide over there. We took immediate femoral access, took a fluoro shot, which is not shown here, which had shown circ to be compromised. We quickly wired the circ, POBA into the circ, got some flow back. On the right, I want to take your attention to the video on the right over there. We looked at that shot and we thought perhaps the haziness there was probably due to dissection, either guide induced or retrograde extension of the dissection. So the next step, we immediately went and spoke to the family and requested that the next best thing would be emergency CABG, which the family point blank refused. So we went in, stented the left main from the ostium with a 4/12 pot, rewired the circ, opened up the circ stud, got flow back, but something did not feel right, and the next stent boost that we took showed this. There was significant concertina LSD of the left main ostial stent over there. We took a couple of shots to understand what was happening. Then we tried to POBA the intraluminal jutting struts over there, pushed it back in, and then we quickly passed the 2526 ZDS down to the distal lady to secure flow over there. Then we stented the left main with an overlay stent, 4512, completed pot over there. There are two things that were visible here. You can see that in the right view there, we can see there is some under expansion of the LAD stent over there at the LM-LAD ostium complex. It was also balanced by the haziness in the circ over there. So we decided to stop here for the day with respect to the coronary work, and we decided to call her 2 days later after she settles down. Now back to this stent that is fractured. We tried to pull it back, but we lost balloon and wire access, and ultimately we took the EBU out. We exchanged it with a JR. We put a snare in, pulled it into the guide. It could only partially come in because the widest part would not come in. We pulled the whole complex out en masse with the sheath, and the stent came out in one piece, although unraveled. The patient was allowed to marinate with an IABP for 72 hours. We called her back 2 days later, optimized the LED stent, the circ ostium was clean, it had healed then, and she went home okay. She's currently doing well. So take home points: stent dislodgement, stent fracture, LM dissection, branch vessel loss, circ loss, and longitudinal stent deformity in the primary PCI. Size mismatch, one size fits none. So never try to squeeze one stent in when there is a clear size mismatch. Imaging regret was a huge problem here because she could not afford the extra, and we had because we underestimated the complications that could occur. All these complications came one after the other. Dissection often has subtle signs. So if we lose one non-dilated branch, several other non-dilated branches could also be involved. So look carefully at the entire coronary system there. Why did the stent fracture? Was it excess handling? Did it fracture at the ostium of that LM-LAD stent? Did it fracture at a calcific nodule over there? Unsure. Slender looking vessels can be diffuse IMH. We as early career cardiologists and fellows are taught that slender vessels in primary PCI have more often than not spasm. In fact, in this case, the one complication that wasn't there was spasm, everything else was present. Short stents in left main, higher risk for longitudinal stent deformity, so we must be careful with that. And sometimes acts of omission can prove to be virtuous. We took a Hail Mary pass and let the circ ostium heal, and it proved to be okay at the end. Thank you.
Ultimately, what do you think? What was the reason of your catastrophe?
Trying to pass a 3.5 stent in an LAD probably that could not take a 3.5 stent. That started everything. Okay. Then spiral dissection, then diagonal loss, hypotension, and then from there, I think a couple of panic moves also from our team. I think also did not help at all. So that was the setup. If we decided just to take 2 stents over there, perhaps we could have gotten it.
Finance was
It was a huge, but I mean that is no excuse.
Okay.
I feel the 2 lessons from this case. The first and foremost lesson is that if you are doing the charity, do it fully. Don't do a half charity, because God is always there. Because every human being, every human life is important. It will not be important for one person. Every human life is important. So if you are doing the charity, do it full. Even if you would not have touched this patient, patient would have there are a lot of patients who are on anti-angiogenic therapies and medical therapies, and they are doing well. So I feel the first lesson is that we should do the charity that we should not do. The second thing is I feel we did not show the final short of an LAD.
Yeah, I didn't because
Because you know we lost two diagonals who had a spiral dissection downstairs, and you did not show the last. So I was very keen to see the last shot of that.
of the LAD during that same sitting I'd shown.
Next.
The next one I did.
And the third thing I feel.
The second I did not.
Okay. And the third thing I feel what is important for the budding interventional cardiologists, that we should be very gentle and soft towards the guiding catheters. And especially when you have a long left main, your guiding is going to stuck in. So always, when you are doing an intervention, always make it a habit of keeping the guiding, especially the EBU, extra backup support, pulled out. Whenever you are pulling the balloon out, it is going to stuck down. So when you are pulling the balloon out, pull the guiding, disengage for some time. You are re-engage it. The only problem is when you are, because we are using, and if you see that left main LAD, it was a tortuous, there was a bend. And when you are using a long stent, 30 millimeter, and you are pulling out that balloon, your guiding is going to go in. Disengage the guiding. Pull it with one hand and pull with the other. These are very basic techniques. The only problem with the present day, today's interventions is that we are very fast in the cases. We have to be very gentle. That's what I feel.
So one more point I want to add on this. While you are doing these left main cases, you have bulky balloon, like you have a 4.55 millimeter balloon, and you deflate and you want to take it in the guide, just wait. Let it deflate properly. Once we are always in a hurry while we are doing, so just don't be in hurry. Let it deflate properly and then take it out. Then maybe our life is much better and easier, and then we can do it.
Intervention is all about patience. It is all about patience. The more patience you have, you will not be here to present such kind of cases. You are only here to present such kind of cases when you are not patient. I feel I have never been on this on this side to present such kind of cases because I am very patient with patients.
Now to say, I went into sorry, but I take it on behalf of my team.
In light of time, I think we are already getting late, and more and more young
Thank you.
people are going to the introduction, so let us go to the next.
It was a nice one.
Thank you so much.
Next is Kalla Jitendra Jain. In nightmares in cath lab, intravascular electropsy guided PCI or diffusely calcified RCA with no read-through.
So, good evening everyone. My case is a case of calcified RCA, which is referred from the outside center. So, this is about a 58-year-old female patient who had multiple comorbidities, diabetic, hypertensive, presented with chest pain, and outside was diagnosed as CAD, unstable angina. ECG, there were some changes in the inferior leads, 2D echo, there was RDFM in the inferior wall with a good LV function. Angio, surgery of a single vessel disease, left system was normal, and RCA, there was a diffusely diseased vessel. So you can see the angio, this is the guide. You can see here, the RCA is diffusely diseased, there's a band there. In the proximal part you can see there is a tight lesion. After that there is a big, almost a small CTO there, followed by diffuse disease until the bifurcation. So this case, as it was referred outside, we thought we'd take electively, and after that we thought we'll take a femoral approach, which gives a better support for this. So 7 French femoral approach was taken, and after that we thought we'll take a good guide, and followed by the CTO wire to cross that proximal lesion with the microcatheter support. And of course, I thought the right process that I would go for a rota, try to modify it because there was a severe calcification down right there to the mid part. And after that, the thing. So initially, I took a JR. Initially, I thought of a rota, so I put a TPI there. So with the fine cross, I initially tried, after the exchange with the run through, I tried with filter exchange initially, but I was initially successful in negotiating the proximal part of the lesion. But after that, I could not negotiate the distal CTO.
So I escalated my strategy with the Gaia wire, and after that with microcatheter support, and on the right side you can see with the guide liner I was able to cross it, and after that I confirmed that it was in the true lumen. Till then, initially the guide was not, you can see in the previous one, the guide I exchanged it because the guide was not giving proper support, so I exchanged it with the AL1. So after that, the pre-dilatation I did it with different balloons, CPO balloons of 0.75, 2 and 2.5. I changed my strategy of going from a rota to IVL after my balloons went off. So I thought I'd do an IVL because for all the severely calcified lesion. So IVL balloon of size of 3.5 is taken, and right from the distal before the bifurcation to the proximal part, I gave almost 80 pulses of of this IVL, and the balloon expanded well. So the patient till then was totally fine. There was no complaint. Hemodynamic stable. ECG was fine. Then after that, I thought I would stunt with the distal part. So 2 long stunts because it was a totally calcified lesion. So I stunted the distal part with 2.75 48 and the proximal part again with another stunt of 3.5 and 48. So till then it was fine, and suddenly I noticed after that the patient became unstable. The pressures went down. It was almost 20. Became unresponsive. Suddenly, the blue code was announced, and we started doing CPR. You can see on the next slide, and multiple shocks were given at that point because the patient went into a state of VT and VF. And suddenly, I noticed when I gave an angiogram that there was no reflow phenomenon. So at that time, I thought because of the extensive calcification modification which I've done with the various balloons, and so there was a calcium embolization which was caused to the microflow vascular obstruction was there. So I took a microcatheter down there immediately till the distal part of the RCA, and I started giving vasculators. So adenosine, nitroprusside, and all the Lelsam and all the vasculators were given. In between, the CPR was being continued, and the pressures were not picking up initially. But after 5 to 10 minutes, suddenly the pressures came up, the flow restored, and I think after that the patient became stable. So the main thing was that when the pressures went down, we always were anticipating that in view of severe calcium, and we do a lot of IVL and this thing, always we need to keep in mind that this kind of no reflow phenomenon can happen. So these microvascular, using a microcatheter support, I think using a good amount of vasodilators, we can save the patient. So the main take-home message, what I wanted to say from this case, is always when you take a complex case, when you feel that there's a lot of calcium, a lot of modifying techniques, you should always be clear about it, that there can be sometimes no reflow phenomenon, and always think that till the end, nothing is it's not a straightforward, and always complication can happen at any point of time. So with this, I think, thank you. If any questions?
Any possibility of air embolism? So spontaneous recovery of slow flow. Go back to few of your angios, where the proximal RCA dilatation was done by, I think, with a balloon.
You had 3.5 IVL for the distal RCA.
Yeah.
And I think it's better to check on IVS before we choose this, because we are using a 3.5 for the proximal and the distal. Because of, we know that we all want to save money. But sometimes if the distal RCA is not, on IVS it is 3. Then we know that it is a 4 atmosphere, but it is, sometimes it can give you trouble in form of slow flow in these kind of units.
Why do you think the slow flow has come? Because IVL, we didn't use rotablation, because it is a stable disease, not a ACS. What do you think? What could be the reason for
So what happened was, when I deployed the proximal stunt, the distal part of the stunt, I used the same balloon and directed the proximal part. Maybe at that point of time, there was almost 2 minutes delay in inputting the stunt. So whatever the calcium was there in the proximal part, there was significant calcium there. So probably that has embolized into the microvascular.
So most probable explanation is because you use air catheter. So when you say observe that one, when you put the AL catheter, you push down, what it causes acute severe AR. It must have caused the compression on the aortic wall.
that caused the bradycardia hypotension, that caused all these things. When you push this, you have this one guideliner is there, and you push the catheter more inside, it has produced acute air that causes bradycardia, hypotension, everything. Go back this one. That is the cause.
The record there was nothing like AR.
No, you will not see, because once you lifted the catheter, it will come down. You go back. What happened? That is acute transient air producer hypotension, bradycardia, everything. That caused all these things. That is the cause for the reflow. No flow. No, during procedure when using air, before the this one, see the air, how the catheter is sitting on the wall. See, now you can see now cardiac contract is coming down. If you see, cardiac contract is coming down. The acute severe AR rate, what is cardiac arrest?
You have totally blocked the
See the cardiac contract.
You have totally blocked the RCA. Go back for guiding inside valve is inflated. And second thing, what could have caused the slow flow is your guideline had gone very deep. And at times when your large is RCA, guideline goes deep, the anatomy of the vessel changes. So it can cause some, if there is delay, it can cause some slow flow. So that was expected because your guideline had gone up to the mid RCA. The only thing is I agree with sir that your guiding was very deep while you were inflating the proximal. So that time was enough to make the gradient. And once the slow flow occurs, the only good thing what you have done is that you put the microcatheter and did the vessel dilation. That was a good thing at that time. That was a very good.
Go back one or two without only proximal RCA.
This is the one you started reflecting. Afterwards, is slowly.
So the guide was heavy actually. If you see here, the guide was. Yeah.
Sinus.
That is the cause.
That is first the guideline you have taken out of the guideline.
After that, the guideline was removed.
Something like that.
Spontaneous recovery of the pressure of blood.
Maybe there was no flow, so at that point of time we given vasculitis.
That's very good.
Yeah.
The beauty of these cases is that these are all iatrogenic nightmares. and the good thing is that all these iatrogenic nightmares are treatable, and we made out these procedures.
Thank you.
Thank you very much. I would like to request Ryan Onsuza to present his topic, broken catheter in nightmare.
Good evening, one and all. So, this is a case of a broken catheter during angiography. This was a 72-year-old male patient, hypertensive since past 20 years, presented to us with sudden onset of shortness of breath, sweating, 3 days ago at a PHC. He was a non-diabetic but a chronic smoker. No family history or any such episode in the past. Following initial treatment by the PHC doctor on the line of ACS, he was referred to us. At the time of admission in our college, his BP was 150/100, pulse rate 98. Rest, JVP, CVS, and respiratory systems had normal time. The ECG that was done showed pathological Q wave with T inversion in the 2-3 AVF and V3 to V6. The hemoglobin, creatinine, platelet, they were normal. Ongoing echo at the time of admission, the LCX territory was hypokinetic and the RCA territory was akinetic, and the ejection fraction was something around 37%. There was no MI. Treatment was given aspirin, atorvastatin, clopidogrel, inoxa, metoprolol, and ramipril. Then we took the patient for coronary angiography. Right atrial approach was taken. Tiger catheter 6 French, 3 cm was used. After inserting the radial sheath, the guide wire was advanced over the guide wire. The guide catheter was advanced with the guide wire, and when the catheter reached the subclavian artery, I felt some resistance, and the guide wire couldn't pass. Even after 2 to 3 attempts, when we were not able to do, then suspected that there must be either the area was very much tortuous or there would be some obstruction there. So we pulled back the guide catheter and took out the guide wire to inject the dye and try to locate what is exactly happening. Is it a tortuous vessel or is there some obstruction? Now, before injecting, we adjusted the fluoroscopy, and then we were shocked to see that the tip was broken and moving to and fro in the axillary artery. So this is the fluoro image. This is how it was. Obviously, we were very much scared. Then we gathered courage and then we tried to pass the guide wire via the broken catheter, thinking that if we are successful, then we'll inflate the balloon and then we'll pull it back. It would become simple. But then we were not successful. After this, we prepared our own snare. Unluckily, that day in our cath lab, the snare catheter was out of stock. Then we prepared our own snare. So the first, using a guide catheter and two guide wires. The first guide wire was put into the catheter and a balloon was passed over it. The second guide wire was also put into the catheter. Now, the distal end of the second guide wire, beyond the distal tip of the catheter, was made into a U-loop and put into the catheter beyond the deflated balloon, which was then inflated to jail the distal tip of the second guide wire. So this will form a U-shaped loop. The proximal end of the second guide wire, which was lying outside of the radial sheath, was manipulated to confirm the change in the diameter of the loop. It can become smaller or larger. Next, when we assemble this, we put this homemade snare into the radial sheath and try to hook the broken tip. So this is, luckily we were successful in doing so. The broken piece was hooked and then slowly we tried to come in. Then this was not safe, so I had to take from the camera. So on the left side, we can see how smoothly it is coming out, reached the anteprovidal fossa. Then in this, sliding over the radius and reached the wrist joint, and then it snapped out. So we don't know how this came out without damaging the radial artery, but then we were lucky in that sense. This was the broken tip, and on the left side of the screen we can see the proximal and the distal part of the broken catheter. Then we went again, and finally we were able to do the angiography, and this was the condition of the coronary arteries in this patient. Mind you, he was a chronic smoker and he was a hypertensive patient but not on regular medications. So after seeing this appearance on angio, we gave patient the option of medical therapy and we continued conservative because even seeing would not be advised looking at the coronaries. So the take home message from my experience, complications are not uncommon in our cath, and we need to have some innovative ideas to so that we can tactfully handle the situation and avoid referral of the patients to especially the surgeon. And before using any hardware, we should always check it. And as much as possible, we should frequently avoid reuse of the hardware. Thank you.
The patient was for angioplasty or angiography? Angiography. Then why the guide was used?
I mean, sorry.
Why the guide catheter was used for angiography?
Diagnostic catheter was used.
See, couple of points here. One, you had not taken the radial angio after you have done so much of putting of the catheter. Radial shot was not taken. That was the status of the last. So that should have been done for the safer side.
Other thing is, I mean, how did you take out en masse or what?
How it came out from?
He says it came out and it was
When we were coming out, because now it has become a U shape. So actually, whatever the size was, now it had become double the size. Because it was a U shape.
The radial artery, radial artery closed. If you are fortunate that it has come out, otherwise you go to arteriotomy and get it out.
The second thing is that you have used the coronary guide wires too. make a move.
Coronary
Yes,
guidewire.
we use coronary. This is not a stent we are talking about. That we have to smear the stent and take the coronary guidewire. What you can do, what you could have done, much easier method of taking this thing out. Exchange that turbo wire, double it, and then pass it. It will make a loop, and then get hold of that loop. There is no need of using two guide wires. There is no use of using this thing balloon. You understand my point? Exchange that guide wire. It is very long. Double it. Put it in the catheter, this sheet. Move it on. When it will come out from that from the catheter, it will become a loop automatically, and to catch hold of it. So your time will be saved. Everything will be saved, and the nightmares will not be there. But you will see such nightmares.
Show the moment when you were taking it out as a one you had. So do we have a short recording of that? So I think radial, if we are trying to take this catheter out, we might have radial tear. So I think the femoral bigger sheet is a better way to just get these things out.
Because of lack of time, I couldn't show the slides, both slides that I had.
These are all afterthoughts. I agree. When you are in the catheter and in stuck in such a situation, you don't know about what hardware you have and what is the backup, what your colleague is there or not. So these are all the afterthoughts what we are discussing, because we are all without the sympathetic drive there. But the sympathetic drive what the person has in the catheter, he has to think about that. The only thing I feel, maybe you may have tried on the same way, because it was a tortuous vessel. You were not able to go there, so you were not aware about how, if you would have approached from the femoral side, how it would happen there. Because you had no and you have not taken the shot off. So you should have taken the shot and then you could have decided whether the femoral or the brain.
The idea of discussing these nightmares is that the next time somebody has it, they should not have goosebumps and they should be able to manage it without having an adrenal interaction.
Next time when we are using the O catheter and you find such kind of broken tape there, so take the long term wire and make it look okay. So don't take it too much.
It is always a good idea whenever you pass a wire to do under fluoroscopy. Because apparently what has happened that here, since the catheter was not going, it got looped, and then when you tried to push, it got broken. Otherwise, normally if it is really tiger, it will never break. If it is tiger.
And I don't feel this is a basic teaching when we were residents. It's a basic teaching that whatever you do it under the floor. You had been manipulating. You were reading it all out that you were manipulating things. But how much manipulation? It was not a simple manipulation. To make a catheter break, you have to have good manipulation.
I was doing I hardly tried 2 or 3 times just to try to push, and then I was very difficult.
It's very rare to see.
While pushing, when you doing fluoroscopy,
Yes, sir.
then you should never push.
Then
If you
I
are
stopped.
under fluoroscopy guidance, if you see that there is any resistance, then you should not push. I think it's like a time you go to
Thank you, sir.
Otherwise, these are very good nightmares to discuss about.
Next I call upon Sugandha Gupta, and tug of war, major complication during VSD device closure.
Wish you all a very good evening. It's slightly away from the coronaries. Coronaries all the way. I am Dr. Pradeep Kumar. I will be presenting this case on behalf of my fellow resident, Dr. Sugandha Gupta. Tug of war, dreaded complication during the VSD device closure. Very similar to the previous case, but all iatrogenic complications don't end up with happy endings. So mine is a 3-year-old child who presented with complaints of recurrent respiratory tract infections. Echo was suggestive of a 3 mm VSD with a left to right shunt and a gradient of about 50 mm mercury. LALV was dilated and the child had mild PAH. Treatment options were discussed, and since there was about 4 mm gap away from the aortic valve, we decided for device closure of VSD.
So I had a 5 French femoral artery axis and a 6 French femoral venous axis. This is a LV angiogram in LO cranial view. Not the best or the most favorable VSD, I should say, but in the 50 plus cases I have done in the past, so many times we have still got away with device closure in such kind of VSDs. So in the right sided image, we can see how we are able to cross the VSD through a J-tipped thermo wire, and once it crosses the thermo wire, it has to be parked either in the pulmonary artery or in the SVC or in the IVC if we are lucky. So here we can see that it's parked in the left pulmonary artery. So here I am snaring the thermo guide wire with a 6 French snare. So I've caught it and I've brought it down. So here we can notice one thing we have to see. There are so many steps in which we have to be careful. So here we can see that it's not formed a perfect hairpin loop. So if it has not formed a perfect hairpin loop, it means that it would have caught some chordae as the wire was traversing through the RV. So it is an indication that there may be some difficulties. So what I did was I pulled back the wire up to the VSD level, and I again crossed the, I had again parked the thing in pulmonary artery, and again subsequently I had snared it. So here we can see that the hairpin loop was better, and now over it I am tracking the 6 French long sheath, Moulin sheath, was tracked along the thermo wire which has formed an AV loop, and so here we can see the next difficulty will be when the 7 French or the 6 French long sheath crosses the VSD. There may be resistance during this stage. If there is a lot of resistance, we have to again look back whether to back out from the procedure. Third thing is, during this process, the child can develop a bradycardia or complete heart block if it bumps into the conduction system. Again, it's an indication that we have to back out. But the sheath freely moved in, and there was no bradycardia at this stage. So next stage is where to park the long sheath. So usually where I do is, it's not at the ascending aorta, it's not in the arch of aorta, just at the junction of arch of aorta and descending aorta. That is where we park the long sheath. But this is one mistake I made here. Possibly the previous case that I did, what happened was, if it is placed close by to the arch of the aorta or ascending aorta, the subsequent hardware that you take, it may pull back the long sheath and it falls back into the LV, and it becomes, sometimes it slips out, and all the hard work that you have done goes for a 6. So over enthusiastic, I have placed it in the descending aorta. So whatever traction I give, it may not be get transferred into the tip of the sheath. So next what I did was, I took a LifeTech 4x7 device, and I got to the tip of the long sheath, and I opened up the LV disc. But now when I wanted to pull back the long sheath, it was not coming out. So I was stuck with that. So with the device opened up, with one disc of the device opened up, we cannot do too many manipulation. So the first thing I did was, I took back the delivery cable and the device back. The idea was to rewire, because a wire access can save a lot of things on a bad day. So first thing I created a AV loop, a wire could pass, thermo wire could pass. Then I wanted to take a dilator, because often there will be a kink at the level of the VSD. So that is what will be preventing these kind of, it will prevent the pullback and all. So I wanted to take a delivery, the dilator across it, but this dilator was not going beyond the VSD level. So possibly there was some obstruction at that point. So some extra force was applied. So then what happened was, there was a tragedy. So there was a sudden giveaway feeling. The sheath was getting stretched, but the tip was not coming out. So it was a braided catheter. So the braided catheter, sometimes it can get stretched endlessly. So next, it was all a very difficult situation. I tried to pass a Amplatz extra stiff wire through the long sheath, and an MP catheter was introduced on the aortic side just to push the catheter and see if something could be done. So it was all desperate measures. Here you can see how I am trying to, I've got the MP catheter almost till the VSD level, but it would not release that. So this was the situation we were in. So adversities come but in series. The long catheter got snapped at the VSD level, and the patient developed bradycardia and complete heart block. So I had very few options left. I exchanged the 5 French sheath to a 7 French sheath on the femoral artery side, and I snared this end of the catheter that was the other end of the long sheath. So with this, with little traction, I could pull back the long sheath into the common iliac artery, up to the common iliac artery.
So this is when immediately the hemodynamics improved, and I was just wondering what to do next. So sometimes over enthusiasm. It was already late in the evening. It's difficult to call back the surgeon. So I thought it'll be a photo finish if I can complete this percutaneous retrieval of the catheter. So what I did was I already had a 7 French catheter in place. So if I can get that exteriorized tip at the 7 French catheter tip, I thought I can pull out it en masse with minimal vessel damage, and that is what I can see me doing here. You see the catheter is taking a V-shaped bend and it is coming out freely. So looked okay, but the problem was the child was hemodynamically stable, but limb ischemia was obvious. Very often these young children have femoral artery spasm also occurs. With some NTG and with some little time, it often improves. So we waited for some time, and in the previous image, if you see, there was no bladder sign as such suggesting any kind of retroperitoneal hematoma. Of course, it was too early. So here the confusion was whether it was spasm or vessel injury. We waited for some time. There was slight improvement in flow. The limb was still warm. We got an ultrasound abdomen. Some amount of flow was there, but there was some small 2.5 to 2.5 centimeter hematoma was there along the external iliac vessel. Echocardiogram, there was no evidence of any effusion or bowel injury. The child developed, with this, the child was shifted to the pediatric ICU, but meanwhile, child developed hypovolemia and limb ischemia. This was a warning sign. Immediately, the patient was taken up for surgical exploratory laparotomy, which showed an avulsed external iliac artery and retroperitoneal hematoma. Vascular repair was done and reperfusion was achieved, and the patient was managed in pediatric ICU subsequently. So this was the sheath that was retrieved, and you can see here how the braided sheath has got extended or elongated endlessly. So this is what, and this is the V-shaped bend with which it had come out. So take-home messages are: child is not a young adult. Vascular complications in pediatric patients can be disastrous. Hardwares used in pediatric intervention should be carefully chosen. Percutaneous bailout may be reasonable but not be complete. So once the catheter was there in the iliac artery, possibly I should have sent the child to surgery. But in adult population we have tried to pull out, as was shown in the previous case. But this cannot be true with pediatric patients. So this is where I went wrong, and try to avoid, but do not hesitate to disturb your surgeon. Surgery backup is a must. Thank you. Any questions? I'll be happy to answer. Any questions?
Wonderfully done.
Thank you.
So now we have oblique of the nightmare and catalog and paparazzi is not enough.
Good evening, everyone. Welcome to the session of nightmares, and I will be presenting you my nightmare which I had.
Can you start the slides?
So this is when perforation was not enough. So this is the topic. I'll show you what the case was. Patient is a 69 years old female with comorbidities of diabetes and hypertension. The complaints were of angina on exertion, diabetes uncontrolled, 8.6% was the HbA1c, ECG left middle branch block with echo showing a paradoxical septal motion, no significant cardiac abnormality, and ejection fraction of 55%, mild MR. This is how the angiogram looked like. So quite a tortuous artery. You can very well see the LED is having a 90-degree upturn after the septal branch, and then followed by diagonal, and diagonal, after the diagonal there is another lesion. The right coronary artery is a non-dominant, circumflex is dominant, with OM having a disease. So the plan was, I'll show you a better image of LED. Now we can very well see the mid LED part after the septal having a tight 90% of lesion, with a with beyond the diagonal branch another lesion of around 70%. Vessels seems to be quite a tortuous one. The procedure was done through transradial route. So wired both the branches, the diagonal to protect the LAD, and the subsequent serial dilatations were done. And after the dilatation, there was then I took a 2.5 into 38 stent, and the stent across the lesion. Okay, so I missed something. So after I did this dilatation of the diagonal, the patient had no flow of LED. So probably after the LED there was some dissection flap must have which have closed, after which the LED has closed. So I did another dilatation beyond the no flow part, and then straight away took the patient for stenting. So took a longer stent from the diagonal, beyond the diagonal to the lower part, and then after the stenting, I could see that there was a mid portion of the stent which was actually had remained unexpanded. And so after that, I thought of post-dilating it after this completion of the stenting from proximal to mid. Then I'll do the post-dilatation. That was the plan. And after this, there was another proximal just after the septal branch. There was looking like a dissection, LED dissection. So I placed another stent from proximal to the septal branch up till the mid LED in an overlapping fashion. So then I tried to go on with the strategy of like that unexpanded stent. So you have to post dilate, but as I was post dilating, you can see there is a type 3 perforation. Type 3 perforation, immediately after the type 3 perforation, hypotension started. Did the balloon tamponade by putting the balloon across the lesion, just proximal to the lesion, and then immediately took the graft master. 2.8 into 19 graft master was taken. The patient developed hypotension, had bradycardia, went into cardiac arrest. This is during the cardiac arrest. I placed the graft master and opened the graft master. And this is after the graft master, the stent, the perforation got sealed up, and okay, the recent result. And then I subsequently completed the procedure by doing the post dilatation with proximal part of the stent. Okay, so there's a now in the last angio, if we can see, which actually which I was able to see later on, but I would like to show you here. In the last extreme right of the slide, you can see just after the guide catheter, you can see that there is some indentation there, which initially I thought it might be something, and so I took different angles, but in different other angle, that particular indentation was not seen. So I just left it. I just thought maybe just a small spasm or something, and I left it there. So this was the final result of the PTCA, but our nightmare has just started actually. So what happened? So there was hypotension. The patient was continuing into hypotension. So echo showed there was a pericardial effusion. So the pericardial this pigtail catheter was placed, and the pericardial effusion was drained. But the hypertension was persisting. Now what has happened when the patient went into cardiac arrest and CPR? So my fellow was trying to put the temporary pacemaker because the patient had a cardiac arrest. So he placed the needle because and the for the pericardial tamponade, the pigtail was placed. Now you can see that indented urinary bladder sign which was seen. So there was some suggestion that might be while doing that temporary pacemaker, maybe he has hit a artery and maybe there is a perforation. The patient is already on anticoagulation, high grade anticoagulation. So might be that is the reason for his hypotension. So what was done was sheath was pulled back, and then there was a manual compression was done, and the last extreme right angio you can see that the perforation in the initial part there is a small leak which we are seeing which has sealed in the last angiogram. I think you can appreciate in the second image there is some amount of leakage which is seen, and in the last has sealed. So our thing was I thought so that's okay, and now we can let the patient rest. So patient was sent to the ICU, and there but the hypotension mean after like half an hour or so the ICU guys again called me up. The patient is not doing well. Patient is continuing in hypotension. So that was again a problem. We brought the patient back into the cath lab, and now we can see that the bladder has actually shifted a lot more. So there was a feeling that might be a retroperitoneal hemorrhage has occurred. So the puncture was done on the other side, took the catheter, and the angiogram was done. Didn't show that great a thing, so whatever, but there is a retroperitoneal hemorrhage. Why would the bladder is going to get indented so much? So we did a balloon occlusion. Balloon occlusion was done, and after the balloon occlusion was done, that part became okay. So we were able to see, but the ordeal continues because now we could see that the patient has gone into stent thrombosis. So then again the wire was crossed, the ballooning was done, and now the indentation which was seen in the previous angiogram is looking more dangerous at this point. So then we stented the vascularity as well, and this is the final result which was afterwards taken. Okay, so this is how the patient went, but the causes of hypotension and was later on the CT. Next day the CT was done. So there was actually a peritoneal hemorrhage which was there. So what has happened when the pericardial drainage was done? Maybe some vessel must have hit, and that has led to, because it was not a retroperitoneal hemorrhage, it was probably a peritoneal hemorrhage which was leaking and has caused all that hypotension. So my take-home message: team effort, because the fellows can be helpful, but they can also cause complications. So be ready with the hardware in difficult situations. Stent thrombosis has actually complicated this case. The peritoneal hemorrhage, that has complicated case. But at the end, the patient went off of the ventilator and was sent off. The patient is still on follow-up. Patient is doing well.
arterial bleed or venous bleed? Because I mean, angiogram doesn't show any major leak.
Actually, there was such a rush going on inside the cath lab. So the bladder got indented. Bladder can get indented only in retroperitoneal hemorrhage.
So I mean, venous injection could have helped. So and second thing, when next day when you did the CT scan, was there any evidence with contrast?
Not so, not so.
Because when you rightly said that I mean it is either because of temporary pacemaker wire or while pericardial tapping normally what probably you can do is damage to liver, that also will be very well seen on CT scan. So yeah.
But the shot you took from the controllator side, there was some ooze from the
Yes, so some ooze was there, but it was not very significant to cause this much amount of hypotension and there. Funniest part was that the pacemaker lead was not even able to get through.
So the second thing is, once you found that there was some leakage from the arterial side from here, though it was not significant, but the patient was symptomatic, he was in hypertension. Did you reverse the anticoagulation?
Yes, we.
That was an issue of causing the thrombus.
That is
should not have been
definitely
done.
that was there, but then there was no other option there.
See, then if you were clear about that the perforation was not that significant to cause that disease, then you should not have reversed it. Why? Because you had already put the covered stent and they are more thrombotic. In fact, I feel this patient should be on the anticoagulation also now.
So what has happened was the patient was continuously, because the hemoglobin was continuously going low and low and low. So there was definitely some amount of leakage which was going through, which has to be stopped.
You were in a situation, you were on the edge of the sword.
Of course.
You were neither on this side or on that side, so you were just trying to get the patient.
Get through the patient, yes.
So the cause of the stent thrombosis maybe
Because of the FFPs which were given. We didn't reverse through protamine, but FFPs were given.
because covered stent already
Definitely, that was part, and I think I mentioned that in the take-home message that FFPs were given, probably the stent thrombosis was there.
We all get stuck and then yes, right, the FFP and all they can lead to stent thrombosis, especially when the graft master is there. So
But one thing, one carry home message from this case is that the resident should not always be made responsible for bad things. They should be responsible for the good things also.
I think we'll close the session.
How to do the complication.